Hello, everyone. Good evening. I am Maria Pellisé from a hospital clinic in Barcelona, and it's my pleasure today to be moderating this webinar, this ESGE webinar on endoscopic full thickness resection, where we have the pleasure and the honor of having two gastroenterologists and endoscopists that are at the forefront of endoscopic full thickness resection. On the one hand, we have Barbara Bastiaansen from Amsterdam UMC, who is the principal investigator for the Dutch EFTR registry, and Arthur Schmidt from the head of the Department of Gastroenterology department at Robert Hospital in Stuttgart, who was the first doing the first publications and has been also the principal investigator, one of the main investigators and authors for the German EFTR registry. EFTR is a technique that is quite new and that is open very new options for treating lesions in the upper and lower GI. So we first will have a talk by Barbara, focus on colon, and then a second one by Arthur, focus on upper GI. And in between, we will have a time for questions, first to Barbara and after to Arthur. So I invite you to put your questions in the Q&A, and please use it. We will try to answer them live, and the ones that we won't be able to answer live, we will do them writing. So please put your questions. So now it's time to start. We will start with Barbara, and that will talk about colorectal endoscopic full thickness resection. Barbara, please, the floor is yours.
Thank you, Maria, and thank you, ESGE, for the very nice opportunity to talk about colorectal endoscopic full thickness resection in this team together with Professor Schmidt. It's a true pleasure. So I'll focus on colorectal EFTR, the lower GI. So these are my disclosures. Yeah, so this is an open door. We all know that conventional endoscopic resection techniques are based on submucosal injection to lift the mucosa away from the muscle layer, and so that it protects against perforation and deep wall injury. And that is, of course, the reason that en bloc EMR is considered inappropriate for non-lifting lesions, while these perforations can happen. These are pictures from the old days. So endoscopic full thickness resection for long was considered the next frontier in therapeutic endoscopy. And that is, of course, if we make intentional perforations of the colon, we must be sure that we have secure techniques to close the perforation, of course, to avoid fecal peritonitis. Now, over the last decades, various techniques have been developed, like over the suturing systems and over the scope clips, to avoid this risk of fecal spill. There are various techniques, exposed and non-exposed, but the non-exposed technique with the Ovesco full thickness resection device is the most commonly used, and is the only system that integrates perforation, closure, and tissue resection in a one-step procedure, as I will explain to you later. So the full thickness resection device is based on the well-known over-the-scope system, or OTSC clip. It's an over-the-scope system that can be mounted on all regular colonoscopes, including the pediatric ones. So it is a modified over-the-scope clip on a cap with an integrated 13mm snare that runs in the tip of the cap, and the snare runs along the outer shaft of the colonoscope so that the working channel is being free for the grasping forceps. You can see there the integrated snare. The cap dimensions are quite larger than we know from the regular over-the-scope clip. It has an outer cap diameter of more than 2 centimeters, and also the diameter is slightly over 2 centimeters, and that is, of course, to allow wall duplication. but it can also cause sometimes some problems, of course. It makes the tip of your endoscope less flexible and more stiff, which can be difficult to maneuver through very angulated or fixated sigmoids, for example. But we know from our registry that most of all right-sided procedures, we can reach the target lesion. We cannot in only 2% of the cases. And when you feel you have a very difficult colon, sometimes it can help to first use a dummy cap, which has the same diameters as the full thickness resection device, to see whether you can reach the lesion, and also to check mobility of the colonic wall when you are in doubt, and that maybe helps to improve your case selection. So I quite use it sometimes when I'm in doubt whether I can reach or mobilize the tissue, and I think it's helpful. So these are the basics. So first, it's usually three endoscopies in one procedure. So first you go in without the device to check your lesion, to mark the lesions, which I think is quite important, because the cap takes away light and visibility, of course, the long cap. So it really helps to recognize the lesion once you are there with the device, because the second introduction is, of course, with the mounted device. And you see already on the picture that it takes indeed away visibility. So then the markings really help to recognize where you have to be. Then the grasping forceps is being introduced, and the tissue is being slowly grasped into the cap. And now it's very important that you start pulling and you don't start with suction, because it runs the theoretical risk of then entrapping adjacent organs like small bowel or ureters, although we did not encounter that in our registry. But it's important we don't apply suction at first, but first pulling, and once your cap is being filled with tissue, you can apply some additional suction to get all the tissue that you need. So then the clip is being released with the turning of the hand wheel, and you see the wide ring is being pushed forward. Then you know the clip is being released, and then only then tissue resection can take place. Of course, it happens with almost pure cutting current to avoid thermal injury to the wound and to the specimen. And the OTSC clip is making sure there is a hemostasis, so we don't need a lot of coagulation. It's almost pure cutting current to go through all these wool layers. So the main indications are, of course, for lesions that are considered intractable or inappropriate to treat with the conventional mucosal or submucosal resection techniques like EMR, ESD. So these are non-lifting or recurrent lesions, of course, that can be very hard to resect safely en bloc because of a higher risk of perforation. And then we have, of course, subepithelial lesions that originate from the deeper submucosal layer, for which it's also quite hard to get a proper lift to have an R0 resection by a snare. And then, of course, we have lesions in very challenging anatomic locations like the appendiceal orifice, or, for example, a polyp that's growing into a diverticula, for which also en bloc resection is almost impossible to achieve with conventional techniques. So, for example, this is a patient who had a PET-positive lesion in his cecal pole. He had a PET scan for a cancer that he survived. And as you can see here, there's a lesion almost circumferential over the appendiceal orifice. It looks quite ugly, not completely sure what it is, but it doesn't look too benign. So here's the grasping forceps. You see the markings are quite tight over the edges of the lesion, not like ESD, we take longer distance, but here the markings should be just around the lesion that you can see whether you pull your lesion in completely. Now, first pulling, no suction yet. First, put some tissue in the cap before you apply additional suction. And I'm pretty sure almost very often we do need to apply some additional suction to get everything in. But don't start with suction. Now you see that everything is in, then the wide ring is being pushed forward by turning the hand wheel, you see the wide ring is being pushed forward. Now I know that the clip is being released, and then only then tissue resection takes place, of course. So here's the third introduction to check the resection site. And there we see the en-bloc resection pinned down on paraffin. And there is a beautiful histopathology slide where you see the appendiceal orifice. It's a sessile serrated lesion. It was with high-grade dysplasia. And you see the full appendix base was being resected. The patient had an appendectomy in his past. So that is a perfect R0 resection. So what we should know about EFTR for appendiceal lesion is, of course, that the appendix can be quite long, about 10 centimeters sometimes in size, and we cannot resect the full appendix with this device, of course. So we only take the base of the appendix, and we know from studies that it's around 1.5 centimeter of the base that we can take. So we should know that, of course, a vital part of the appendix is being closed off with the clip, and that runs the risk of a secondary appendicitis for patients who still have their appendix, and that risk is around 20%. What also you should remember is that when a lesion is growing deep into the appendiceal orifice, and that's something you cannot see from the inside, then of course you don't really have control over the deep resection. So it is possible that the deep resection is not clear, but usually the polyps are not growing so deep in the appendix. So we still have R0 resections of around 80% for appendiceal lesions, but that's something you should be aware of. And also this appendicitis risk is something, of course, patients should be well consented to. Okay, so, but I think maybe the most progressive indications and one of the most interesting indications is probably T1 colorectal cancer related, both as a primary treatment for suspicious lesions like an excisional biopsy, also when deeper submucosal invasion is present, or it can be used as a secondary completion treatment after a previous incomplete resection of a low-risk T1 CRC. For example, this is a video of a primary resection. This is a patient of around 70 years old. We are in the ascending colon, as you can see. There is this non-granular depressed type lesion here with a clear suspicious center. It looks like a deeper invasive cancer. So the markings, again, quite close around the lesion. It's running over the fold. So the markings really help to recognize, again, with this device on top. It's very important. We only open the grasper outside the cap because the diameter of the grasper is wider than the inner dimensions of the cap. And when you open the grasper inside the cap, you can dislodge the integrated snare. So only open the grasper outside, then start pulling. And once your cap is being filled with tissue, you can apply some additional suction. You see nicely all markings are coming into the cap. There are also the lateral margin, some additional suction, and now clip is being ready to be released. By turning the hand wheel again, the wide ring is being pushed forward, tissue resection, go back, and then a third introduction will follow again. So this delivers this type of histology where you, of course, have the full wall layers underneath, and pathologists are really fond of this because it's so easy to check all risk factors in these T1 cancers, and it really helps for almost 100% of accurate risk stratification in T1 cancer. So is it necessary, a transmural resection? Well, I think very often for T1 colorectal cancer it is. First of all, we know from studies that around 50 to 60% of all T1 colorectal cancers are size 2 centimeters or less. So that's the target size for full thickness resection. What we also know is when we look critically at the R0 data for ESD, which has been performed for T1 colorectal cancer, we see that it performs exceptionally good, of course, for superficial invasive cancers with R0 rates up to 92% in experienced hands, but it really drops to 60% when invasion turns out to be deeper than expected. And the problem is that in the majority of all T1 colorectal cancers, deeper submucosal invasion is already present at the time of diagnosis. And I always tell my fellows, also, if it really looks like cancer in our eyes and with all the scopes that we have, it usually is deeper than SM1. You have to be really lucky to get an SM1 cancer. You also see that in this very nice paper recently published by Ohata. This is a prospective Japanese series, more than 1,800 ESDs, colorectal ESDs. As you can see, only around 280 of these 1,800 were actually for colorectal cancer, so for T1 colorectal cancer. This is in Japanese hands. They perform ESD for superficial invasive cancers, but already here you see that 50% of them have invasion deeper than expected, so T1B. So half of all cancers were deeper than initially expected. And what is interesting, and I think it's very important to still stress about, I think many know already, but deep submucosal invasion is not a strong risk factor and not an independent risk factor for lymph node metastasis. We have performed this meta-analysis that now clearly shows that it is not an independent risk factor. And if you have a deep submucosal invasive cancer without any other risk factors like lymphovascular invasion or tumor budding or poor differentiation, then the absolute risk of lymph node metastasis is less than 3%. It's only 2.6%. So it's so low that we should reconsider whether deep submucosal invasion should be an indication for oncologic surgery. Since we know that around 40% of all these deep submucosal invasive cancers have no other risk factors. So a significant proportions of these cancers can be cured when we are able to resect them en bloc and an R0 resection, of course. So this is the first study. Artie was working on it. It's already being published in 2019. This was from the German registry. It was 156 patients. So primary non-lifting lesions that turned out to be a cancer. So it was not a full thickness resection for a suspicious cancer, but the lesions were primary non-lifting and turned out to be a cancer. And it turns out that indeed it leads to an R0 resection rate of 71.8% in this study, but accurate histologic risk stratification was possible in nearly all cases. More recently, the Dutch registry published their results on T1 colorectal cancer cases. So these were 330 suspected T1 colorectal cancers. The Dutch are quite progressive. So also when a lesion looks deeper, submucosal invasive, we think we can, it's suitable for endoscopic full thickness resection, we would go for this this resection. So we have 132 primary resections in this in this paper. Mean size around 15 millimeters of the lesion, mean specimen size nearly 3 centimeters. And we see an overall R0 resection of 82%, but we should consider that 60 to 70% of these procedures were deep submucosal invasive cancers, and also 10% was T2 cancers. So these R0 resection rates compares favorably to the ESD data that we have for colorectal cancer. What is also interesting is that if you see if you consider deep submucosal invasion as a risk factor for lymph node metastasis, the strict curative resection rate would be 24%, like we see that in ESD data. But when you exclude deep submucosal invasion as risk factor, you see that the curative resection rate goes up to more than 60%. So a significant proportion of patients can be spared radical surgery. So, as I said already, it delivers optimal histology by, of course, including the muscularis propria. And I'm showing you these data. I'm a little bit in doubt of the submucosal plane is good enough for the majority of T1 colorectal cancer. So it offers an extra chance for R0 resection, also for the deeper infiltration lesions. So it expands our treatment options for deeper SM invasion, but also scar excisions after previous incomplete resection for low-risk T1 CRC. But of course, for these last scar resections, we still don't have data or no prospective data to whether it's safe or not. So it's still we should still consider it as an experimental approach. The medium-term follow-up for the T1 colorectal cancers in our registry is being presented at the UAG week, sorry. So I'm very excited to present this data in a few weeks of time, but I cannot show it, of course, right now. But maybe if you're interested, you will. The abstract will be online soon, I think. I discussed this regarding the scar excisions. We don't have any prospective data, but we are running the local study right now. It's a prospective observational multi-center study in the Netherlands from the EFTR working group to investigate, of course, the feasibility and the oncological safety of additional scar excisions. So we follow patients for 5 years with active surveillance after scar excisions. In our registry, from our registry, we know that in 11% of all scars, there's still residual cancer. So we have to go for 153 inclusions. We are halfway by now. So this is coming. So of course, one of the major limitations of the full thickness resection device is, of course, the size limits. And we know that for T1 colorectal cancer, the majority the invasive part is almost never larger than 15 millimeters. So it can be interesting for the larger, for example, like here, this is a lateral spreading of granular type lesions with one suspicious part, but there's this extension here that looked completely benign. Altogether, this lesion was around 25 millimeters, just slightly too large for en bloc and resection with good R0 resection rate. So that's why we decided to go for a piecemeal EMR for the non-invasive part and leave this suspicious part for the additional full thickness resection. Now it's downsized to around maximum maybe 18 millimeters. So now it should fit. Of course, the invasive part we should be able to really demarcate the suspicious part to be able to do this. And it's still very experimental, but I think it can expand the indications for T1 colorectal cancers that are size larger than 2 centimeters. So I think we've seen enough of these videos now, but it worked. As you can see here, this is a deep submucosal invasive cancers nearly invading the muscle layer. So this is a nice paper from Germany. It was recently published in GIE, indeed, about hybrid EFTR, so combined EMR and endoscopic full thickness resection. It was a single center study, 75 cases, median size 30 millimeters with complete macroscopic resection in 97% of the cases. There was follow-up for these cases with recurrence in 11% of cases, but could all be treated endoscopically. 16% turned out to be cancers, followed by surgery in the majority of cases for high-risk features. And the conclusions of this study, I think it's interesting. Of course, it's the first largest series, but it shows that it's safe because there were no adverse events except for severe adverse events, except for one, appendicitis for appendiceal lesions. So the study concludes that hybrid EFTR can be safe and effective for larger adenomas that cannot be approached by EMR or EFTR alone. I showed you this data, and there's a very small case series from the Netherlands with intentional hybrid procedures for larger T1 colorectal cancers, only 6 cases. As I said already, one critical point is that you have to have a unifocal, well-demarcated focus of cancer. In these 6 lesions, it turned out well with R0 resection of the invasive part in 83% and no cancers in the EMR resected species. But these are, of course, very limited number. But I would look forward for larger numbers for these this hybrid technique. And I also look forward to maybe comparative studies to ESD. But we don't have that yet. We don't have any comparative studies. So main outcomes come from the German and the Dutch large prospective registries. They both show the same results. So technical success rates are between 84 and 88%, and R0 resection also around 82%. Also, adverse events are quite similar, around 10%, most of them mild to moderate, but perforation range from 2 to 4% with emergency surgery for perforations or appendicitis in around 2 to 2.5%. I will come back to that maybe later about the complications. Also, a meta-analysis has been published on the outcomes of endoscopic full thickness resection in last year in GIE. Most of the studies are small and retrospective, or but also the Dutch and the German registry are in, of course. Also here about the same results. So technical success rate of 86.5%. R0 resection rates approaching 80%. Adverse event in this meta-analysis slightly larger, 15%, but that's also maybe because the exposed full thickness resection technique series are in this, so not only FTRD case series that might explain a slightly larger adverse event rate, in my opinion. I think I can skip this because it's quite the same. Also, if we check lesion size in this meta-analysis, we see that regarding technical success, there was no significant difference. We do see slight lower R0 rate for lesions larger than 2 centimeters, but it's not significant. But well, if we look at our experience and also from the registries, we know that I think 2 centimeters for a lesion is a nice cutoff for endoscopic full thickness resection. If you go higher than 2 centimeters, especially for scarred lesions, the risk of not ending up with an R0 resection becomes much higher. So it all depends on wall thickness, of course, and mobility, but I think a good cutoff could be 2 centimeters. Now, this is a recent study from Arthur's group and from the Dutch endoscopic full thickness resection working group, and we collected our data to nearly 1,900 procedures. And I think overall, it's what I've already shown you. The perforation rate is 2.5%. Half of them were immediate perforations, and that's usually because of the wrong sequence of steps were followed. The other half were delayed perforations that almost all, of course, required emergent surgery. But from our data, we now see that the delayed perforation rate is below 1%. So it was 0.9% of all patients needed emergency surgery. And the majority of those cases were located in the left side of the colon. And I think that's an important remark to make, is that we really advised to give stool softeners for left-sided procedures, just to keep the pressure in the colon not too high, to avoid delayed perforations. We have the feeling it helps to avoid the delayed perforation. So already showed the secondary appendicitis rate also in this study is around 20% for cases that still have their appendix in situ. Half of them can be treated conservatively, and the other half of patients need appendectomy or a cecum resection. So it's something, this risk, that should be patients should be well informed about this risk. So how we do it, I think it's very important you motivate your patients for a really good bowel prep, because even the cleanest colon looks can, with the long cap, can collect all the fecal remnants. So it's very important that the bowel preparation is good, especially for right-sided lesions. Both deep or conscious sedation can be used, and we usually schedule 75 minutes for right-sided lesions and 30 to 45 minutes for left-sided lesions. That is, of course, because we need 3 colonoscopies in one for the right-sided lesions. That can be sometimes time-consuming. We don't give any antibiotic prophylaxis except for appendix cases without a prior appendectomy. We still give them 5 days of antibiotics just to avoid the secondary appendicitis. We don't admit our patients. They all go home after 1 hour of observations. And I still think EFTR in the lower rectum is maybe not the right technique. The lower rectum is thick. It's not mobile. And also, if you go below 5 centimeters of the dentate line, patients, of course, you run the risk of severe pain after the procedure. So we always advise not to perform EFTR in the last 5 centimeters of the rectum. We still give our patients a clear liquid diet until the next day, and very important, we prescribe stool softeners for 2 weeks after the left-sided procedures. Yeah, so to wrap up, I hope I'm not talking too long, but I think our conclusion is now that colorectal EFTR is an established and should be considered an established endoscopic resection technique. It shows high technical success rates, R0 resection rates, and I think if you compare the alternatives for these, for these complex lesions, the complication rate is acceptable, and it can avoid unnecessary surgery in a large proportion of cases. Of course, it's important to have hands-on training, and it really helps if you have at least a volume of around 20 cases per year. I strongly have the feeling it really helps if, of course, you do it more often. Well, we discussed the main indications, and I think it's clear. Also, the T1 colorectal cancers, I think, is a very interesting target for EFTR. And again, 20 millimeters is, I think, a good cutoff to consider for the maximum diameter for an R0 resection. Well, thank you very much for your attention, and I'm very happy to take your questions.
So, Barbara, thank you very much for your presentation. That was really comprehensive. We are running a little bit late, short of time, so there are plenty of questions in the chat. I will just go to 2 questions, and then we will change to Arthur, so he has time to give his presentation, and then we will have more questions at the end. So first of all, what would be, considering T1s especially, or suspicious of T1 cancers, what will be your indications? When will you decide to do an ESD, or when will you decide to do an EFTR or hybrid EFTR? How would you when do you choose one of the other strategy?
Yeah, that's a good question, Maria. So I must say, if it's smaller than 2 centimeters for all, whether it's superficial invasive or looks deep submucosal invasion, we choose primary EFTR and not ESD, especially, of course, outside the rectum and especially on the right side. Yeah, and then hybrid EMR, EFTR, we still, well, it's experimental. So it's usually for patients at higher surgical risk. It's something we can offer to our patients depending on what their wishes, of course, and we do sometimes give patients the option, but it's not, you know, it's not something that is a regular procedure for larger T1 colorectal cancers.
And then I have another question, because we are always talking about lesion size, considering like a large diameter, but my feeling with EFTR, it's important also the volume of the lesion, because some lesions may be not very large in terms of diameter, but they are quite sessile, so they can fill in the cap, and maybe you are not able then to do a full thickness resection. What is your advice on that?
No, I completely agree. It also depends, of course, on the volume of the lesion. But yeah, when you are really in doubt, you can use the proof cap. But if the lesion is voluminous but small, in my experience, it's well possible to get a full thickness resection. And we do have the full muscle layer in 80% of all procedures. So
and do you use the grasper as well when you want to test? Like, do you only use the cap, or do you also use the grasper, the proof?
Yeah.
That's a question by Nuria.
Yeah, if I use the proof cap, then I use a separate grasper as well. Yeah.
That's what right. Okay. So thank you very much. There are plenty of other questions in the chat, but I think we need to move to the next speaker, and then at the end, maybe we can continue answering some of the questions. So the next speaker is Arthur Schmidt, as I was saying, from Stuttgart, and he has been at the forefront of EFTR, and he will talk about upper GI, which is the new part of to explore with EFTR. Please, Arthur, the floor is yours.
Thank you, Maria, for the kind invitation, and it's really a pleasure to be here. And I would also like to thank the ESGE, of course, for inviting me. So those are my competing interests. And yes, so we heard a lot about the colonic EFTRD in the wonderful talk by Barbara. And my task is to talk about EFTRD use in the upper GI tract. And as you probably know, there is the so-called gastroduodenal EFTRD, which is a dedicated device which is approved for resections in the stomach and also in the duodenum. It looks basically very identical to the colonic EFTRD system, as you can appreciate on this image. However, it's slimmer. It has an outer diameter of 19.5 millimeters. And the set also comes with a 20 millimeter balloon, which can be used to facilitate per-oral introduction and to facilitate passage through the pylorus if necessary. So there is not too much data about the EFTR in the upper GI tract, so I will focus my talk on clinical aspects. I will show you the indications, the possible challenges, and I will also show you some video cases from our centers. Now, what is the indication of EFTR in the stomach? I think the only indication is to resect small subepithelial lesions with a maximum diameter of about 15 millimeters. If you try to resect bigger lesions, you will have probably difficulties to entrap the lesions into the cap. You may ask, why should we resect those small lesions? We can also observe them. These are, of course, a diagnostic resections to get a histologic diagnosis. And in case of malignant tumors, these are ideally, of course, therapeutic resections. In the duodenum, we can also address, of course, small subepithelial lesions like this subepithelial neuroendocrine tumor on the left side of the screen in the duodenum, but we can also aim, of course, similar to the colorectum, for non-lifting epithelial lesions like non-lifting adenomas, which is shown here on the right side of the screen. Now, the resections in the upper GI tract are, I think, different to those in the lower GI tract. We have to face different challenges and difficulties. The first challenge is to reach the target lesion. We have two anatomical obstacles for introduction of the device. The first is the upper esophageal sphincter, and the second is the pylorus. So this can be sometimes difficult, and I will show you some examples later. The next thing is the mobilization of the tissue into the cap, which is the most crucial step for the resection, of course. Sometimes it can be difficult to grasp the subepithelial lesions. It may also be difficult for lesions which are arising from deeper layer of the GI wall. And then, of course, the stomach wall is more thick compared to the colon, for example, and it's even more difficult in the antrum compared to the corpus, in my experience. Also in the duodenal bulb, it can be also difficult to incorporate the duodenal wall. And then we should also, of course, think about complications which can be quite different to the colorectum, and I will also show you later 2 slides. So let's start with the peroral introduction. So with the novel device, this usually works actually quite fine. However, there can be cases where the introduction is difficult, like in the video case. And in those cases, you may use the introduction balloon. You can see here that the balloon is introduced on the endoscopic side into the esophagus, and it's inflated. And then with the inflated balloon, the FTRD system is then advanced through the upper esophageal sphincter. So this is actually not a dilation procedure, but the balloon actually serves as an accessory to basically facilitate safe introduction of the big and sharp device. I have not seen any complications after introduction of the device yet. Most patients claim about a sore throat after those procedures. But I have not seen any perforations or severe lacerations of the esophagus so far. So this is a clinical case in the duodenum. This is a patient with a subtle, small, recurrent, non-lifting adenoma with high-grade dysplasia in the second part of the duodenum, difficult to access by EMR and other conventional endoscopic techniques. So this is a good case for EFTR. Here you can see how the device is introduced through the esophagus and through the stomach. Then the target lesion is reached, and then the resection basically is very similar to the colonic resection. So the lesion, which was marked before with coagulation spots, is again grasped with the grasping forceps, and then the tissue is mobilized into the cap. In the duodenum, it's mostly a little bit more difficult than in the colon, because the lumen is also narrower, and I think the duodenal wall is also a little bit thicker, but still in this case, this worked quite fine, and you can see the resection specimen. It was a complete resection, R0, and also in the follow-up after 3 and 6 months, there was no evidence of recurrence. So this was a quite successful procedure. This is another duodenal case. This is a patient with a subepithelial tumor with unknown histology prior to resection in the second part of the duodenum. Again, you can see the resection steps, the marking of the lesion, and the device is introduced through the esophagus. We are now in the stomach, and now we reach the pylorus. As I said, sometimes this can be difficult to pass, but usually this works quite fine. As I said, if it does not work, you may use the dilation by balloon to facilitate the passage. And then in this case, we used Actually, I like to use for subepithelial lesions, I like to use the anchor device. As you can see here, this allows a very good tissue mobilization in case of those subepithelial lesions. And the resection in this case went very fine. You can see here the resection specimen. And this was actually a neuroendocrine tumor, which was R0 resected. And this was also a curative procedure. This is another case, quite easy case in the gastric corpus, a small neuroendocrine tumor about 1 centimeter in size. So those are the typical cases which I would recommend to start with in the beginning. You can see that again we used the anchor for grasping of the lesion, and you can see that this lesion, this was a very superficial lesion. And you can see how nicely this lesion and also the stomach wall can be incorporated into the cap. You can also appreciate the coagulation margins. When the clip is released, you actually saw the white ring slipping the clip down, and then the snare is closed and resection is performed as you have seen it in the other videos. And this resection went also fine. So this was also very fast, 20 minutes. And there were no complications, and this was also an R0 resection. This was a low proliferating tumor, so we also consider this resection to be curative. Okay, so this is a more difficult lesion to address with the FTRD. You can see it's larger. It's in the prepyloric antrum. From the macroscopic appearance, it was likely to be also an ectopic pancreas, but the EOS, as you can see, was somehow inconclusive. It was very hypoechoic, and so we were not sure if this is a GIST. And in this case, we had concerns that we would be able to entrap the lesion completely into the cap. So what we did, we decided to do a circumferential incision with the ESD knife to incise the mucosa, just to facilitate the entrapment of the tumor into the cap. And then again, you see how the anchor is placed into this depression in the center of the lesion, and the circumferential incision actually, at least this was my feeling, allowed us to quite nicely entrap the lesion into the cap, as you can appreciate here on the video. And the resection actually went quite fine. Clip was placed and snare was closed and so on. So I had a feeling that the incision really helped to do this. This was the resection specimen. However, you see that on the resection side, there is still some residual tissue, and this was strongly suspicious of ectopic pancreas, of course, and this was also confirmed by the pathologist. So not a complete resection, but we clarified at least the histologic diagnosis. But still, it was incomplete, and we thought, how could we improve this? And you can see this on the next video. This was also a borderline to resect lesion arising from the muscularis propria in the gastric corpus. And in this case, we also did a circumferential incision, but here we decided to do a complete unroofing of the mucosa. So we removed the complete mucosa from the tumor, just to be able to visualize this well and to be able to place the anchor not only in the submucosal space, but really directly into the tumor. And we were hoping to be able to resect this completely, although it was quite deep in the gastric wall. And you can see that the incorporation of the tumor into the cap was not easy. It took a while, and we needed traction and also some suction. But still, we were then able to resect this. So the clip was deployed, snare was closed, and the tissue was resected. And you can see here the resection site. And this was a macroscopic complete resection in the proximal gastric corpus. Here's the resection specimen. And luckily, this was an R0 resection, and the pathologist confirmed that this was indeed a GIST with a low proliferative index. So this was also a complete and curative resection. So this is also a more difficult case in the duodenum. This was done by my colleague Armin Kühlmann. This is a patient with a recurrent adenoma in the second part of the duodenum with a central non-lifting part. It was about 2.5 to 3 centimeters in diameter. So this was also a case where we thought, okay, this will not happen with a pure FTRD approach. So as Barbara demonstrated before, we used also a hybrid approach, which in this case means that we started with an FTRD and resected the lifting part of the lesions. No, we started with an EMR, sorry, and we resected the lifting part of the lesions with the snare, and then completed the resection in the same session with the FTRD device. And those are the pictures. So this is the adenoma again, and then this is the picture after the EMR. You can see this residual non-lifting part of the lesion. And then we went ahead, as I said, in the same procedure like you have seen before in the colonic cases, and completed the resection with the FTRD device. You can see that this is somehow a little bit bloody, of course, and the vision is not very good, but still we were able to do this. You can see the pulling of the lesion into the cap, and then the resection was performed as you have seen before, and you can see that this is not easy, but still it worked. We were able to complete the resection of this large lesion actually, and this went fine. There were no complications. The resection site looked good. There was no evidence of perforation or bleeding, and also the pathologist confirmed that the central part of the lesion was resected completely, and in the 3 months follow-up, the clip was still in place actually, but there was no evidence of a recurrent adenoma. So I showed you resections which went fine all, but we still will encounter complications, as we have experienced this also in the lower GI tract. We also fear perforations. This is a case of a patient with a subepithelial lesion in the corpus. Resection went fine, but when we pulled out the endoscope, we saw that the clip was still on the cap, and this resulted actually in a very large perforation, as you can see here on the image. Luckily, we were able to close this immediately with 2 over the scope clips, and the patient was doing fine. But please keep in mind that those kind of perforations are avoidable. So make sure that the clip is released, make sure that you see the white ring, and then and only then you can do the resection. Also, I would like to mention that we should be cautious if we do resections in the duodenum. The most important thing is to keep distance to the papilla, of course. So make sure that the lesion is at least 1.5 to 2 centimeters away from the papilla. If you do not see the papilla completely, use a duodenoscope just to make sure that the papilla is far enough away. And also, I would like to stress, and all experienced endoscopists know that the duodenum is quite prone to complications in terms of bleeding, and also if a perforation occurs, the management may be more difficult. So just keep this in mind. Okay, so I will just very briefly show you some clinical data. We have a lot of data, as you have seen in Barbara's presentation, about the colonic FTRD system, but we do not have very much data on the use in the upper GI tract. This is a table which basically shows all the available data. So small studies, only 1 uncontrolled prospective study. So really actually not too much to report about. Just very briefly, this is a nice study by my former colleague Benjamin Meyer from the Ludwigsburg group. So he did a prospective study on a resection of gastric subepithelial lesions, small lesions up to 15 millimeters. And the results were quite good. Technical success rate 89%, and the R0 resection rate 76%. So quite similar to the colonic data which we have seen before. And also importantly, they were able to achieve a sufficient histological diagnosis, including proliferative index and so on in all cases. So this data is quite good. I think those were our first, was our first series on duodenal use. I will skip that. And this is today the largest study on the duodenal FTRD. This was also done by my former group in Ludwigsburg, 20 patients. Data was quite good concerning complications and also concerning technical success. However, as you can see here, the R0 resection rate was not optimal, 63.2%. This was maybe due to the fact that at this time we were not very experienced in the use of the device, and maybe we included too advanced lesions. So this is a thing we should address in the future, I think. There's a very similar study with 10 patients by an Italian group. For the sake of time, I will skip this. Quite similar results. And this is probably the largest study available now on EFTR in the upper GI tract. This was a US study. So they collected data from 56 patients from 13 international centers. We also put our data from Freiburg in there. Various indications, 84% of lesions located in the stomach and 14% in the duodenum. Technical success was quite good, 93%. However, also in this case, I think the R0 resection rate is not optimal, 68%. So there is room for improvement. However, there were no severe adverse events, which is good news, I think. All right, so I would like to conclude and summarize. I showed you that the gastroduodenal FTRD is, I think, a very valuable device, which now allows resections, full thickness resections in the stomach and in the duodenum. The indications are subepithelial lesions up to a size of 15 millimeters, I think. And also we can address non-lifting adenomas in the duodenum, which was not possible before by conventional endoscopic techniques, I think. So it's a quite valuable device. And our personal experience is quite good. However, we do lack good data on efficacy and safety. There are very few studies available, no prospective larger studies. I already mentioned that I think we need to think about how to enhance resection success, and especially R0 resections in borderline to resect lesions. And I think the hybrid techniques I showed you may be a solution for that. However, I think the optimal strategy is still to be investigated. Okay, thank you very much for your attention, and I will be happy to answer questions. Thank you.
So thank you very much, Arthur, for this forefront presentation with these wonderful videos. So I think we still have a few minutes for discussing. And first of all, I wanted to ask you, because I have seen very technical things. I have seen that you were using the anchoring system for the upper GI. Do you also use it now for the lower GI, or is it something that you specifically prefer in the upper GI?
I actually prefer it for submucosal lesions, which are probably a little bit deeper in the GI wall. So it's not a specific thing about upper GI, but yes, it is, because subepithelial lesions are more common in the upper GI tract, of course. but I always use it when I think I will not be able to grasp the lesion properly with the forceps.
Yeah, and to the both of you, do you think that there are some technical improvements that can still be done on the device? Because one of the things that I don't like at all, and I suppose that it's the same for you, is that there is a moment that you have like a little bit of a blind spot. You don't really see as much as you would like what is going on, for example, or maybe also that as the cap is long, I suppose that that makes it very rigid, and I suppose that especially for the duodenum, that has to be something that it's probably a problem, no? Because you have the lesion very far away sometimes, so you need a distance.
Well, this is those issues you mentioned, those are true. I also have experienced that, of course. But those things are quite difficult to address technically. We're always thinking about that, and we're working closely together with the company to further develop the device. The thing is, it's always a balance. So if you make the cap shorter, which will improve visualization, you will not be able to entrap too much tissue into the cap, right? So, and we thought that the actual length of the cap now is a quite good balance between being able to capture tissue and having a good visualization. And it's the same with the diameter of the device, right? So for complete resection, you would like to have a large diameter, but if you make it too large, you will not be able to introduce it. That's why we made it actually a little bit smaller. So I think there is some room for improvement, but it's quite difficult. I think one improvement in the future might be that the company will improve the clip design so that it's not too sharp anymore on the outside, which will facilitate introduction through the upper GI sphincter and also through the pylorus. But it's always a trade-off.
And again, one other question that is in the chat, do you know how long the clip stays in the bowel, more or less? And do you know if, in case you haven't done an R0 resection, what is the probability that that lesion that may be on the top of the clip will disappear by themselves, or what is your feeling about those two things?
Barbara, do you want to answer?
Yeah, sure. The first question, no, the question about what's the chance that the tissue, you are not R0, but what is the chance that the tissue will, necrotize and fall off? Well, it will not. So the clip is designed that the tissue stays, of course, healthy and vital. Otherwise, we would have a lot of delayed perforations. So no, it's not that the tissue in the cap will fall off. So if it's not R0, it will not, it will not go away. That's very important. And I forgot the first question. What was?
How long the clip usually stays?
Yeah, we know from the registry in the colon, it's on average somewhere around 4 months. And we never have patients that have found the clip in their stools, so they lose it around 4 months time. In 80% of cases, it's off within 4 months. If you have not an R0 and you want to treat the same spot, of course, there are devices to cut the clip, like clip cutters, and remove the clip. But that's also, of course, it's only safe after, well, let's say at least 3 to 4 weeks, I would suggest. I don't know, Arthur, if you agree with me, but...
How do you do that, Arthur? How do you manage when you have one of these situations where you would like to go back to that lesion and the clip's still there?
Yeah, well, I would remove it with the remove system, which is available from the company, which is also approved for the indication. It's sometimes a little bit tedious to do that, so nobody likes it actually, but it works. We also published a study about that. So the clip removal is usually possible in over 90% of cases. There are some cases where the clip is really overgrown with tissue, then it can be sometimes difficult. But if clip removal is indicated in case of retreatment, let's say it's nearly always possible with the device.
And Arthur, another technical question. What about the esophageal lesions? And there's a question on, is it, for example, to use an overtube, will that help?
I would actually not recommend to do esophageal EFTR with the FTRD system. I think it will not work probably. There was actually one case in the study I showed on the last slide. I'm not sure about the details of this case, but I would not do EFTR resections in the esophagus.
And do you think that to use an overtube will help to go through the upper sphincter or the lower sphincter?
We have a big enough overtube to push an FTRD through. I think this will be even more traumatic if we would have one. No. And in most cases with the modified device, so in the beginning of our experience, we used the colonic as an off-label use for upper GI, and this was really difficult to introduce. But with the novel gastroduodenal device, it's really in at least 9 of 10 cases, it's working fine. You don't need an overtube.
And then to another technical question, that when you have this difficulty, for example, first question, there is one question on the anchor. If you want to take it away, is it easy? Can you put it and place it and replace it several times?
Yes, you can do. So you can close it and open it as often as you want. So if you pull and it tears out, it causes sometimes a little bit of bleeding. Same with the forceps actually, but basically you can place it several times if needed. And in some cases it is actually necessary to place it 2 or 3 times. Yeah.
And what are your tips when you have these lesions that don't want to get into the cap, for example, scarring lesions, and to avoid like to have it like the tissues breaks and you have a lot of bleeding? How do you do that? How would you try to remove one lesion like this one? Like you already know that it will be difficult to grab it into the cap.
Barbara, you want to answer?
Yeah. Well, I think for the very scarred lesions and the previously treated lesions, we also see that in the registry that the R0 resection is less good than for primary treated lesions. So first of all, if you have a very scarred lesion, then don't aim for lesions, 2 centimeters or larger. I think maybe 15 millimeters is a good size for scarred lesions to get your R0 resection. And I think you need patience also, patience to allow the tissue to get into the cap, and don't start suction immediately, but slowly pull, let the tissue move in. Also, I think it's important if you have a scarred adenoma, not to place your grasper only on the adenomatous tissue, because that's quite soft and it bleeds very easily. And if it's possible, I would place the grasper just underneath in the healthy colonic wall, where you have much firmer grip, and then start pulling from there than on top of the adenoma. If you can grab it underneath at the base, it's much better and a better grip and less bleeding, because I totally agree, it can become very difficult to have good visualizations once you have to replace the grasper. I always get very nervous from that, because it gets you have not a very good overview. So I think maybe 2 or 3 replacements, fine, but that's the maximum, and then it just doesn't work. Also very important, if you really think you're not R0, if you really feel I don't have it all, then just don't fire the clip, don't go for the resection. I see that sometimes, I have the device on, let's just go for it, but I don't think we should do that. So only go for it when you really think you have everything you want.
Okay. And Arthur, there's one, because even if, as Barbara has said, only 1.5% of delayed perforations, it is still something that we don't like, because that will be a peritonitis if it is we are in the colon, and we don't really know what happens in those cases. No, you had this theory that maybe it's the wall that is too tight. Do we really know more about it? And does it happen in the upper GI? Can this happen in the upper GI?
Well, it's the same with anastomotic failures. They are much higher in the colon than in the small bowel. It's because of the the bleeding and the circulation is optimal in the small bowel. They don't leak. Small bowel anastomosis don't leak, and I think the risk of delayed perforations in the duodenum will be less than in the colon. For the cases that my personal experience, all those cases with delayed perforation were in the early days when I didn't prescribe laxatives. So I really believe in laxatives for left-sided lesions, because those patients always told me the same story. At day 3, very intense urge for defecations, very difficult. Of course, you have some luminal stenosis. You do a kind of a wedge resection, so there will be some stenosis there. And when the stool is very, firm, I think it can. Well,
do you want to add anything, Arthur?
Yeah, I totally agree with Barbara. One more thing to consider is that patients which are immunocompromised are more prone, of course, to delayed perforations, especially patients on immunosuppressants like renal transplant patients. They are really prone to those events, so be careful about that. And the second question was, can it happen in the upper GI? Yes, of course. And I have seen actually one case of a delayed gastric perforation after an FTLD case in an otherwise healthy woman, and I still don't know why that happened actually. And a third thing I would like to add, I have seen some perforations in cases where the FTLD procedure did not went fine in the first days, where the snare was not working, and if you then go ahead and do an additional resection with a conventional snare because the first snare did not work, those patients are, I think, prone to secondary perforations, because sometimes you entrap the clip and then you do apply current, and then this may cause coagulation damage to the underlying bowel wall. So just be cautious with that.
Two short questions. One for you, Arthur. Can we do EFTR in retroflex position? Have you tried that?
Yes, I have tried it. And yes and no. I had cases where it worked and I had cases where it did not work. Usually, if you can reach the lesion with the inverted FTLD, it works. So the clip releases actually. It's a little bit more tedious, of course, but it worked. But there are some cases where just, even if you have the retroflex position where you just can't reach the target lesion. It's difficult, and it's not a case which I would recommend to start with. But yes.
But it's not impossible. And then the question that I think is relevant, especially in the upper rectum, can we have an MRI after doing an EFTR? Does the clip artifact the MRI?
Yes, it artifacts. It gives artifacts. So if you think you need an MRI for staging, then do it before. Yeah.
Good. So I think that there are still many other questions, but I think that we managed to cover most of them. So I really thank you for your thorough, very comprehensive, very clear, plenty of videos, very practical and presentations, and that you were so generous to share your super expertise, which is great. Thank you very much. And thank you for all the audience that is still here, even if we are 50 minutes away from schedule. So thank you very much for everyone. And now we are going to finalize. And I will use these last minutes just to tell you that it's good to be from ESGE and to tell you that please come and renew. And also that now it's the open application for the ESGE research grants. So good for you to come, and that we wait you at Berlin this year, that we will have the Jubilee. So thank you very much to all of you, and looking forward for the next webinar in 2 weeks.